Or the basal cell carcinoma. So basal cell carcinoma is also called as a rodent ulcer. So it is the most common malignant tumor. Okay, most common malignant tumor, which arises from basal cells. Hence the name basal cells of the pilosebaceous adnexa, which occurs only on the skin. Hence the name basal cell. And generally, it is a slow-growing neoplasm which may present as ulcer of chronic duration. So, important thing to remember is metastasis and death from this disease is rare. Coming to the common site, so it is also called as a tears. It can be called as a tear cell carcinoma because it is present in the tear zone. So we know that the tears fall from the eyes. So there can be a question where all the options of the site of the tumor can be given, but you have to remember that it does not present in the upper eyelid. It starts from the lower eyelid and goes downwards. So hence it is present in the tear zone. So inner canthus, outer canthus, eyelids, bridge of the nose, around the nasolabial fold, site of the area where the tears are rolled down. Hence BCC is also called as a tear cell cancer. Then we have the nevoid basal cell carcinoma, which is one of the component of the Gorlin syndrome. What is Gorlin syndrome? Is a inherited medical condition where multiple body systems which are defective, such as skin, nervous system, endocrine system, eyes, and bones. So here, along with the nevoid, along with the BCC, there can be inborn kyphoscoliosis and anomalies in the rib. What are the other lesions present, like ovarian fibroma or odontogenic tumor? Okay, so coming to the precipitating features, so we know most of the skin cancers are precipitated by ultrasound waves, especially the UVB rays. So it's also called as a sunburn rays and possibly responsible for BCC. BCC is common in areas like Australia and New Zealand because of this reason, because UVB is more common and the people there are light skinned. Fair skinned individuals are vulnerable for the development of BCC, and also arsenic is once used as a skin ointment can also increase the risk of the BCC. So here we have to remember three important points: ultraviolet rays, the fair skin individuals, and arsenic. Coming to the clinical features, the clinical feature is most common presentation is ulcer which never heals, and sometimes it can lead placed with the scabbing which later break down and form an ulcer again. So ulcer has a raised and beaded edge. Very important is the rolled and pearly white rolled out edges. Pearly white edge is seen in which ulcer, that is BCC. It may be indurated and bleeds on touch. The base may be subcutaneous fat or deeper to it. When the lesion is big, it is called rodent ulcer. So typical feature of BCC is that it is locally invasive. So it spreads vertically and it starts eroding into the depth of the skin from the surface. Hence it's called as a rodent ulcer. Scabbing typically occurs only in the benign ulcer, and basal cell carcinoma is the only malignant ulcer which shows scabbing. Okay, which shows scabbing. Now it is a painless form, and which are pigmented with fine vessels. So it can be given in the question that it is associated with telangiectasia. It may be presented with ulcerative nodulocystic variety, and field fire rodent ulcer typically is a rapidly growing rodent ulcer with destruction and disfiguration of the facial skin. Which is the most aggressive form is the morphiform, and most common is a nodulo-ulcerative. Most common is nodular, in that nodulo-ulcerative is most common, and the most malignant or aggressive form is morphiform. So what is the differential diagnosis? Important is keratoacanthoma, which can be present as which occurs only over the face, and the edges may be raised with ulceration that is resembling the basal cell carcinoma. Then is a sclerosing angioma, malignant melanoma, squamous cell carcinoma. Spread is by local invasion, and very important is it does not spread through lymphatics. Lymphatics is not a mode of spread, and blood spread is also extremely rare. So how does it is a penetrative local invasion, as I told you. Then morphiform form BCC synthesizes type 4 collagenase, therefore spreads rapidly. White scar-like growth pattern is seen in morphiform. So this classification is not that important. Coming to the investigation we have the wedge biopsy from the edge of the ulcer. So why do we prefer the edge? Because edge is the growing part, and so the malignant cells are numerous, and also it has a central slough. So this slough for the scalp does not reveal any malignancies. Okay, so coming to the microscopic picture is very important for MCQ point of view. Peripheral palisading of the columnar cells with the cells of cell nest and keratinization with mitotic figures absent. Sorry, cell nest with the mitotic figures are absent. So coming to this, so we see that the cells are arranged parallel to each other. This is called as peripheral palisading of the which cells? Columnar cells. So basal cells are columnar cells. So here you see. Coming to the treatment is surgery followed by reconstruction, which is the main mode. In surgery is indicated when the lesion is very close to the eye, adherent to the cartilage or the bone in very accessible areas. Wide excision is done in all the cases. This means that the excision of the growth is with the at least 3 to 4 millimeters of healthy margin. Primary suturing of the defect if the lesion is small, and skin grafting if the defect is big, and rotation flap for face for better cosmesis. So important is the name of this one, reconstruction with the nasolabial fold, and what kind of this one flap is used is bilobed nasal flap. Okay, also rhomboid flap, banner flap, other things are used. Coming to the another important thing is the Mohs micrographic surgery. So here it is a special type of surgical technique which involves the excision of the skin cancer under the microscopic control. So it minimizes the chance of recurrence and conservation of the surrounding normal tissue. So basically, if this is the ulcer and this is the skin surface, and it is a rolled out ulcer, as I told, pearly rolled out ulcer. So under the microscope they keep excising the part of the tissue. This is the first part excised, and they look in the microscope and they see if there is a presence of tumor cells, and they keep going down and down and down. So every time they take a slice of the tissue, they see it under microscope and to see if there is any cancer, until they get a clear margin. Okay, indication is a central facial located tumor, large tumors with poorly defined tumor margin, lesions with perинeural perivascular invasion, tumor at the site of prior radiation, and tumor in settings of immunocompromised and high risk histological subtypes of BCC. What is a radiation? Radiation is used for extensive lesion requiring a complicated reconstruction. Dosage is 4000 to 6000 centigrade. Other forms are small superficial. It is used using curettage or with the electrodissection. You can treat it. Liquid nitrogen can also be used for a tumor if it is less than 1 centimeter in diameter, and carbon dioxide laser can be used. So all this is not that important. So finally we will revise it in 1 minute. So first thing, important thing is you should know that it is a okay, we'll revise it. So first, it is also called as rodent ulcer, most common skin malignancy. Metastasis and death is extreme rare. A common site is line joining this outer earlobe to the lip, corner of the lip. That is inner canthus, nasolabial fold, tear cell, carcinoma, and all of that. Remember Gorlin syndrome? It's a BCC is a part of the Gorlin syndrome. And then we have the precipitating factors like UVB, then and the fair skin, arsenic. The clinical feature, it presents as a ulcer. What type of ulcer? Raised and beaded ulcer, which is indurated. And then we have, if the lesion is big, it is known as rodent ulcer. It's usually painless, firm, and nodulo-ulcerative, nodulo-cystic, or field fire. Then morphia type is more aggressive, and more common is nodulo-ulcerative type. Differentials, we know keratoacanthoma may be asked. Local invasion slowly penetrates the tissue, does not spread by lymphatics. Important. Investigation is wedge biopsy of the ulcer edge, and then we have surgery, which is wide local excision. Primer suturing, skin graft, and rotational flap can be used. Bilobed nasal flap is used, and then we have the Mohs micrographic surgery. Other forms of treatment are radiation and curettage and liquid nitrogen. That's it.